Hey guys, the point of this AMC Mastery video series is just that because Australia doesn't have a lot of information, the Australian Medical Council, the information on it is really sparse, and for IMGs who are looking to migrate into the country or to take up a job in Australia, it's really hard. I mean, there are some really good websites, YouTube video series, the training academies out there, but there's not enough, and there's nothing that actually explains each and every condition in detail. One of the biggest problems that IMGs often face is, where do we start? What do we do? Because there is just not enough information out there. So the whole point of the series is that go through the video and I'll try to run down the basics of how to get into Australia, how to start working as a doctor in Australia, how to apply for a registration process, how to clear your first exam, things like that. Hey guys, my name's Surat, and I've been working in Australia as a doctor for a while now. When I initially started my journey, I was quite confused because there was not a lot of data out there on the internet. I was very unsure where to get the process started, how I proceed further, what sort of registration do I do, what sort of jobs do I apply, how do I prepare for the AMC. It was all quite confusing. So the AMC Mastery is basically an attempt to sort of streamline all that data so that in case if anyone's looking in to come to Australia and start working here as a doctor, you sort of have a guideline to go through. So I hope this helps. So what are the pathways into Australia for a doctor? Basically there's 4 pathways. You have the standard pathway, the competent pathway, the specialist, and a short-term training in a medical specialty pathway. As of today, there was an update by the Medical Board of Australia saying that they are trying to come up with a new specialist training pathway. So I suggest that try to keep updated on that. So for most doctors coming into Australia, we follow the standard pathway. The standard pathway is the only pathway that is regulated by the AMC. The other pathways such as the competent, the specialist, and the short-term training, the STT pathway, are all regulated by the respective colleges. For example, the Australian College of Emergency Medicine or the Ranscock College, they have their own specific criteria and specific pathways. But for now, let's focus on the standard pathway. So the first question is, what is AMC looking for? This is often quite a big problem because most of the doctors who try to come into Australia are already qualified doctors. Sometimes if you're an intern or somebody who's just graduated from medical school, it's actually a little easier because let's say you've graduated from medical school, you finished your internship, you've been working for 3-4 years, and maybe you've even specialized or in a residency training program in a country other than Australia. The knowledge and the skills that you pick up are quite different and even advanced as compared to an intern level. But the AMC only looks to assess you and compares you to a newly qualified graduate of Australian medical school who's yet to begin their intern training. So what actually ends up happening is that sometimes the knowledge you have, you end up having more than what is required, and that ends up actually hurting your chances to clear the exam. So let's talk about the AMC CAT MCQ. So the word that clearly stands out here is CAT, that is the Computer Adaptive Test. It basically means that the difficulty of the questions adjusts based on your performance. We'll just get into that in a moment. The next thing, it's an MCQ. You have 5 options per question. It's a single best answer format, and good news, we have no negative marks. The whole exam is a 3.5 hour exam, and it's administered at control locations run by Pearson VUE. So as I said, let's talk a little bit about the CAT or the Computer Adaptive Test. So as you can see, let's say there's three pools. You have pool A, pool B, and pool C with increasing marks. Pool A has 2 marks, pool B has 4, and pool C has 6. So you come up with the Australian Medical Council comes up with sets of questions and sort of categorizes them into different pools of increasing difficulty. Half of these questions are taken from pool of previously calibrated questions, and the remainder questions are new questions that have not been previously used in an AMC MCQ examination. Okay, so these new questions and all the candidates' responses are eventually inspected and calibrated before coming up with the ultimate score. Okay, so let's say you start giving the exam, and the first one is a random selection from pool A, which has, let's say, 2 marks. So don't take these as fixed numbers. This is just guesswork. There's not exact information out there as to how AMC exactly runs their exams, but this is just like a rough overview. So you start the exam and there's a random selection done from pool A, and you're lucky or you're smart and you get the first answer right. So the next question that you get is from pool B. That is, it's a more difficult question. It has more marks. You answered that correctly as well. Pool C, now let's say that's 6 marks. Right, so your first question carried 2, second question carried 4, and the third question that you answered carried 6 marks. But now you make an error. It can either go back to pool B or sometimes even back to pool A. So do you understand how the system works? So the whole point of a computer adaptive test was that research has found that using a CAT format, a shorter test equates to basically a shorter test can equate to a much larger test. So instead of carrying out a test with 500, 800 questions, stretching them out over 4 to 6 hours, as some organizations do, the AMC has come up with this test which can sort of guess how qualified you are in a much shorter time interval. Now, who passes, who fails? What happens is, because of the CAT component of the examination, there are some candidates who would have been administered difficult questions, whereas some would have just gotten easy questions. So even if 2 people end up answering the same number of questions right, like the first guy answers 100 questions right and 50 questions wrong, and the second guy answers the same, the first guy can pass and the second guy can fail. So understanding how the system of the computer adaptive test works is very essential before starting your AMC. So what does the MCQ actually assess? It assesses your ability to analyze medical information and solve clinical problems. Then it also does your clinical examination, diagnosis, investigation, management of common conditions, as most exams do. Ethical and legal considerations of healthcare are something that require quite a bit of focus because they're often different from wherever you've studied. And the last thing is, it also exercises your ability to discriminate, judge, and reason in distinguishing the correct answer and the other plausible alternatives. When you actually go through a few of the AMC questions, you're like, right, option A, B, C, D are all correct. You can exclude one because that one's obviously wrong, but 4 options all seem reasonably correct for the question given. So in these cases, what the AMC wants you to do is exercise your judgment and pick up that one single best answer. Now, as discussed, it's a 3.5 hour exam. It has 150 questions, out of which only 120 questions are scored. 30 questions are pilot questions, and these questions are sort of thrown in all everywhere in the exam, and you never really know whether you're answering a scored question or a pilot question. The second thing is that you are expected to finish all 150 questions, because if you don't finish 150 questions, even if you, let's say, do 149 questions and the time runs out, the computer has difficulty sort of putting you on the AMC adaptive scale, and the examination result is recorded as insufficient data to obtain result. So all of your hard work that you've put in answering the 149 questions goes to waste. So you have to finish all the 150 questions. You need 500 marks in total and you need about 250 to pass. The passing score varies based on the year and cohort of test takers. So that is something that's not really in your control. So I advise that you don't worry much about it. So this is the exam. This is the exam format. You have adult health, adult medicine, surgery. There's women health, gynec, pediatrics, mental health, population health, and ethics. Okay. So the majority of the multiple choice questions here reflect common clinical conditions. So after I finished my AMC and eventually started working in Australia, one thing was quite surprising is whatever the clinical scenarios were given to me in AMC were the sort of clinical scenarios I was actually seeing in the healthcare system. So it's almost a very accurate representation of what actually happens in Australia. Now, how is AMC different from the other exams, say exams for other countries like the UK, US? So the AMC often tests reasoning over rote learning. Most of the times they don't expect you to know any values. Even if there's a range of normal value, for example, the normal pH, it's actually given in brackets in the question, so they don't expect you to rote learn. It covers all the critical areas that are required for a doctor. It focuses not just on life-threatening illnesses, it also focuses on safe practice, including professionalism, not just how you behave with patients, but also how you behave with other doctors, other colleagues, nurses, paramedical staff, and so on. Obviously, successful clinical outcomes an important aspect of public health. There are certain notifiable diseases. There are certain diseases where you have to sort of inform the patient not to drive. There's a lot of different conditions like that we'll be discussing in the next videos. But yeah, it focuses on all of these. And for everyone who's actually even thinking of giving AMC, what I would suggest is go to the link given here and just take the trial exam. It doesn't take a long time. It's only 50 questions. Right now, when I checked it yesterday, it was free. Normally it charges $25 for a trial exam, but right now it's free. So just go give the exam and understand how different the exam is as compared to all the other exams you've given before. So some bonus tips and updates. Yes, so till about recently, a few years ago, you could go back to a previous question, but now once a question has been answered, you cannot go back to a previous question and change a response, because if you do, as discussed, the CAT, the computer adaptive test, sort of the mechanism fails. So once you click next, you can never go back and change your question. You have to answer all your 150 questions. That is very imperative. And as I said, there might be multiple partially correct or multiple plausible answers, but there's only one single best answer. And the final thing is start your prep early. The whole process of applying, preparing takes a very long time, and we tend to underestimate the time it takes. So sometimes we go, oh, it'll take me a few months, but sometimes just the process of application might stretch on for about 6 months, and so start early. So the whole point, so once since we're done with this rough introduction, I just figured we'll discuss a couple of questions, right? So the first question, it's on the screen. A baby is born at term by ventouse delivery with light meconium staining of the liquor. At birth, he's slow to breathe. His APGAR scores at 3, 5, and then 9 at 10 minutes. Which of the following components is the most important for successful resuscitation? So look at this question. There's a lot of data given in the first 3 lines. Takes a while to read. AMC questions have been getting longer and longer as time passes. But does it really tell you much? I say no. Basically, the whole question can be summarized into what is the most important factor for a successful newborn resuscitation. Isn't that what he says? A baby was born in distress. APGAR scores were bad, slowly improved. And what is the most important for successful resuscitation? So the answer to this is obviously quite straightforward. It's adequate Ventilation. So whenever you look at any neonatal resuscitation, it's quite different from newborn resuscitation. It's quite different from pediatric or adult resuscitation. We'll be discussing all of these in the next upcoming videos, but it's important that in all neonatal or in especially newborn resuscitation, ventilation is the most important intervention. Just like how you say in adult resus or adult cardiac arrest situations, CPR is the most important factor that determines survival, CPR and defibrillation, right? But here in newborn resus, it is ventilation. So yeah, just a line out of newborn resus. If a newborn is apneic, gasping, or has a heart rate less than 100 beats per minute, you first sort of dry stimulate the baby, and if the heart rate is still low and the neonate is still apneic and gasping, immediately initiate positive pressure ventilation. Some statistics to know that most babies, approximately 85, initiate spontaneous respiration on their own. A small percentage, 10, need some amount of drying, some amount of stimulation. Only 3% require positive pressure ventilation and 2 require intubation, whereas only 0.1 require chest compression. It's a very small amount. So as I said, ventilation is the most important intervention in newborn resus. Next, so just go through the question, pause the video if you want. Which one of the following is the most likely diagnosis? So once again, fairly straightforward. The answer is a breath holding spell. So I'm just going through these questions in short. I plan to go through these questions separately, topic by topic, in quite detail later on. Okay. The answer anyway is quite simple. It's a breath holding spell. Basically, when it comes to a breath holding spell, children often cry, scream, they breathe out forcefully, and then they hold the breath, as obviously says, and then they become blue, cyanosed, and this is mostly just because of a lack of oxygen, and they can become floppy, lose consciousness, and obviously once they lose consciousness, they start breathing again and they regain their color and come back to consciousness. There's some features about this that might confuse people between seizures and breath holding spells, because there's that sort of post-ictal-ish confusion that is seen in breath holding spells. I wouldn't call it post-ictal confusion, but even once a breath holding spell has passed, the child may be drowsy and sleepy for some time. So that is one area where you get confused with seizures. And the second thing is that because of the transient breath holding and the cyanosis and the lack of oxygen, child might actually throw a small seizure. These seizures are generally not harmful, they're very rare, but in this case he did have some sort of a brief tonic-clonic seizure, but the answer is a breath holding spell. There's 2 types of breath holding, blue spell, pale spells. Blues are more common. Yeah. The next one is a 26-year-old woman who's been diagnosed with schizophrenia. She lives with her parents. She has a gradual onset of symptom. She's stable on amisulpride 800 mg. She's never worked but continues to attempt to find employment. She has difficulty concentration. Which one of the following is most likely to be associated with a poorer prognosis? So once again, know that the questions are really big, but the crux of the question is really small. Actually, it's quite straightforward. Once you go through the whole question, it's basically which of the following options are associated with poorer prognosis in schizophrenia. So there's a lot of tables out there that just sort of give you good prognosis, poor prognosis in schizophrenia. If you gone through one of them, it should be enough. So the answer here is poorer prognosis is insidious onset of illness. Clearly, as you can see, that insidious onset of illness, a long duration, any past psychiatric history, with family history, with no support, not being married, presence of structural brain abnormalities, all these things are associated with poor prognosis as well. High dose of antipsychotic, living with her parents, somatic sensory deficits, these are not really associated with poorer prognosis as well. Okay, Next question is a little interesting. So there's a 35-year-old woman who presents following an intentional overdose. So she calls the ambulance herself, doesn't give you any details. On examination, she's irritable, uncooperative, quite abusive, her BP seems fine, she's a little tachycardic, temperature is alright. So obviously you get the beta HCG done. Which one of the following is the most important investigation? So basically we look at the fact that she's taken sertraline. Now what is the investigation that you need to do? Is it an arterial blood gas, blood alcohol, urine drug screen, ECG, or paracetamol? So pause the video, see if you can answer the question. If not, alright. The answer is a paracetamol level. Lots of text on the screen, but it's important. One very important thing that you should know is that paracetamol levels must be obtained in all cases of deliberate self-poisoning, whether it is an adult or pediatrics. Now, talking about sertraline overdose, there's a few things we need to consider when we talk about SSRI overdose. One, there's a risk of seizures. Two, there is a risk of QTC prolongation and causing torsades. And three, there is a risk of serotonin syndrome. All right. Seizures are not that common with sertraline. They are more likely with citalopram. Overall, quite rare. Torsades is very rare. QT prolongation occurs only with large amounts of citalopram and escitalopram. And risk of serotonin syndrome is present, yes, but when isolated SSRIs are taken, the risk is usually benign as well. And in cases of paroxetine, fluoxamine, and sertraline, the clinical toxicity is usually mild when ingested in isolation. So going back to the question, this is a very good explanation of how answers can seem correct. So we know that it's an SSRI overdose. So in all poisonings, we end up getting an ABG, right? Yeah, makes sense. Blood alcohol level, once again, makes sense because patient could be intoxicated, something that you would want to do. Urine drug screen, obviously, maybe she's taken some amphetamines, maybe she's taken some marijuana, maybe she's consumed something else. You'd like to get an ECG to look for any QTC prolongation, and you'd like to do a paracetamol level. So if you actually think about it, all the options are more or less in a way correct. But the most important or the best answer in this case would be paracetamol. Why? Because an ABG is a little non-specific in this condition. She's stable, she's not hyperventilating, she's not acidotic, her BP seems fine. But maybe you get an ABG later on, but it's not the most important. Blood alcohol level would not change your intervention or your treatment at present. Urine drug screen is the same thing, wouldn't change much of your intervention at present. ECGs, yes, I would have chosen that if paracetamol level was not there. ECG should be done. But now the thing is, as we discussed in the next slide, if it was citalopram or if it was, escitalopram, then we could have considered an ECG. So the best option is paracetamol level. Okay, go through question number 5. So basically, in short, a 45-year-old woman calls up the GP and says, I think my daughter is depressed. I want information on her. The daughter is 18 years of age. So what is the most appropriate action? So the confusion, take a moment to guess the answer. But the common confusion that happens in these options is, one, obviously nobody is going to say, look, she's 18, so we're not going to discuss the daughter's depression with her. But maybe you can just advise option E, advise that you've not seen the doctor as a patient, but that would be lying, right? So you're not supposed to lie, so that's clearly not an option. Now look at option C. Telephone the daughter now regarding the mother's request. So the minute you do that, you are sort of getting yourself involved in something domestic, and you're putting the daughter in a very uncomfortable situation. And you're also sort of giving out information that maybe the daughter has been coming to see you indirectly. Discuss the daughter's depression with her. Option B, that's definitely not to be done. Ask that she attend with her daughter at the daughter's next appointment. Maybe that is something that you can consider if option D was not present. Advise her that you cannot discuss any other patient. So it's a flat out statement that doesn't reveal any data about you, your patients, or the daughter. So option D is the answer. If you're above 14, parents or guardians cannot see health records without explicit permission from the patient. Because going back to this question, if the daughter was, let's say, maybe 16, 15, that would have made it more difficult, wouldn't it? 18, yes, everybody is sure, they're an adult. But what about if the daughter was 15? The same rule. So anybody above the age of 14 automatically sort of have complete control over their own health record. So if somebody asks for it, you can't disclose it unless there is explicit permission. If there is somebody less than 14, the data can be shared with the parents, unless once again explicitly that the child has said that you cannot share the data. There are some exceptions to confidentiality, obviously, where the patient consents, where there's a disclosure to third parties necessary to treat a patient, or you're compelled by law. This gets a little tricky, especially if the parents are separated or divorced, and it requires a whole lot of discussion separately as well. So guys, that's it. I'll be posting more videos soon. Let me know if there's any specific pattern of videos that you'd like, if you'd like just to focus on questions, or if you'd like to focus on a thorough, in-depth classes just taken on individual topics like gout, arrhythmias, schizophrenia, things like that, just separate classes. Right.